Thank you for the kind introduction. Dear colleagues, the better we understand the pathophysiology of a disease, the better we are able to treat the disease. And therefore, it is important to know in detail the pathophysiology also of cardiogenic shock. We also need a definition to define what is cardiogenic shock. It is a state of a critical end organ and tissue hypoperfusion due to a reduced cardiac output. The criteria are that you need to have hypotension for a prolonged period of more than 30 minutes, or vasopressors required to achieve a systolic blood pressure more than 90 millimeters of mercury. Presence of pulmonary congestion or elevated LV filling pressures, and signs of impaired organ perfusion with at least one of the following criteria: an altered mental status, cold, clammy skin and extremities, oliguria, increased serum lactate, and this recently was very well defined by the group of Holger Thiele in Eurointervention. The pathophysiology results from an inadequate perfusion to meet the metabolic demands of the tissues. And in cardiogenic shock, there is a maldistribution of the blood flow to the end organs. This results in cellular hypoxia and organ dysfunction, but also damage, and this may lead to the development of a multisystem organ failure. The major organs that are of vital importance, are the organs that we critically need to survive, are the heart, the kidneys, and also the brain. In the heart, depressed coronary perfusion may lead to a worsening of cardiac dysfunction. Reduced renal perfusion will lead to a diminishment of the glomerular filtration rate, oliguria, and renal failure. And decline in the cerebral perfusion will lead to an altered mental status, ranging from somnolence to confusion, sometimes delirium. What about the incidence? In modern cardiology, the incidence is the cause of cardiogenic shock is still 80% of the cases related to an acute coronary syndrome. 5 to 15% of the acute MIs, despite modern therapy, are complicated by the development of cardiogenic shock. And today, the mortality still approaches 40 to 50%. And the majority of the patients who develop cardiogenic shock have multivessel disease. Already in the shock trial, it was demonstrated that 80% of the patients with cardiogenic shock was related to acute LV failure, most often related to an acute coronary syndromes. In a minority of the patients, you also have acute mechanical complications that also can contribute to the development of cardiogenic shock. And this observation emphasizes that the need to always think when you see a patient in cardiogenic shock, you should always think, does this patient not have a mechanical complication of his myocardial infarction? In a more recent registry, the Shock study, 81% of the patients had an acute coronary syndrome, and 10% of the patients had a mechanical complication of an acute MI, ventricular septum rupture, papillary muscle ruptures, and free wall ruptures. There are other causes of cardiogenic shock listed on this slide. There are a number of non-ischemic causes of cardiogenic shock, and in addition, we have to make a differential diagnosis. Think about sepsis. We have to consider hypovolemia. vasovagal reaction is associated with hypotension, but it is not cardiogenic shock. And we also can have hypotension related to the use of medication. There is good news since we have more effective with our reperfusion therapy by performing primary PCI in the majority of the patients. We see that the development of cardiogenic shock is decreasing, as illustrated in this slides taken from the AMIS Plus registry performed in Switzerland. There is an increase of use of percutaneous revascularization, and this results clearly in a decline of the incidence of cardiogenic shock. So if we want to treat cardiogenic shock, the better we perform this reperfusion therapy, the lower the risk the patients will have to develop this cardiogenic shock. What is the main pathophysiological mechanism is ischemia and damage of the myocardium that results in dysfunction of the left ventricle. And this is an ongoing spiral because of the ischemia. Thus we get progressive LV dysfunction, and this aggravates this spiral, ongoing spiral aggravates continuously, and in many patients will result in death. The systolic dysfunction results in a decrease of the cardiac output in hypotension that will decrease the coronary perfusion, that will aggravate the ischemia, and thus that will stimulate again this deadly spiral. Also, there's the diastolic dysfunction in an acute MI that leads to stiffening of the heart with elevated filling pressures. This will lead to high pressures in the lung circulation with lung edema, with the development of hypoxia. That will aggravate also the ischemia, and that will contribute to the development of progressive LV dysfunction and ultimately death. Now what happens in addition is that because of this, you get a number of compensatory mechanisms. There's the activation of the sympathetic system that tries to keep the blood pressure at a higher level, but because of the situation of cardiogenic shock, you get hyperperfusion of the tissues all over in the body, and this results finally in damages in the tissues with the release of DAMPs, these damaged proteins, and these damaged proteins, they will induce an inflammatory response syndrome, the so-called systematic inflammatory response syndrome, that will lead to the development of multi-organ failure. This inflammatory response syndrome will lead to the production of reactive oxygen radicals that will aggravate the inflammation, that will lead to a decreased sensitivity for catecholamines, that will lead to a depression of contractility, and this will further aggravate the haemodynamic situation. So this also is a vicious cycle. Because of this inflammatory response syndrome, we get this shock begets more shock. And we are with this inflammatory response syndrome. It is a similar situation as happens in septic shock. In septic shock, you also have a severe inflammatory syndrome. They're not triggered by DAMPs, but with PAMs, pathogen-derived proteins that will stimulate an immune response, and that may lead to hypertension and also a depression of the LV function and a cardiomyopathy that also can be result in death of the patient. How can we intervene on this deadly spiral? We can, of course, perform reperfusion, but if you are in a situation where you have that kind of the systemic inflammatory response syndrome, you still have that kind of septic shock equivalent that is present in your patient, and therefore dus we need, many patients will need mechanical support to overcome dus the deadly period of this immunologic storm that is happening in patients with cardiogenic shock. There is indeed, if you look at cytokines in the blood, there is an increased release of cytokines that can be measured in the circulating blood, and the higher the level of cytokines in the blood of patients with cardiogenic shock, thus the worse the prognosis is, as shown on this slide. The disturbances that happen in the microcirculation, this can be monitored with intravital microscopy on the buccal mucosa, but that is not really this methodology that is used in many critical care units. We also have to consider that in some cases our treatment may lead to a worsening of the development of cardiogenic shock, and in a number of patients we also have the situation of iatrogenic cardiogenic shock. If we treat the patients with strong diuretics, this may cause hypovolemia, and this may lead to hypotension. The use of beta blockers, if the patient has sinus tachycardia and we administer high doses of beta blockers, this may also lead to a decrease of the cardiac output, and because of this to hypotension. Also, if the use of ACE inhibitors and nitrates may also lead to iatrogenic cardiogenic shock. And a special situation is dus the right ventricular infarction, dus the traditional method to treat patients with right ventricular myocardial infarction is to expand the circulating blood volume by administering this saline or other this fluids in order to improve the cardiac output and the blood pressure. When we administer dus a too high volume of fluid to those patients, this may actually lead to a worsening of the hemodynamic condition with, again, lowering of the cardiac output and hypotension. This slide explains what may happen in right ventricular myocardial infarction when you start to administer too high volumes of intravenous fluid. Then you get an expansion of the right ventricle, and thus in right ventricular infarction there is an impaired diastolic function of the right ventricle, thus there is less compliance of the right ventricle. And because of this, in many patients, when you look at the pressures, you see a square root morphology in the right atrium pressure and also in the right ventricular pressure. And when you start to administer these high volumes of intravenous fluid, because this stiff right ventricle, the pressures will go up. And now the right ventricle and the left ventricle, they are both constrained within the pericardium. If the right ventricle starts to dilate, because of the presence of the pericardium, this will lead to a decreased filling of the left ventricle, and this will contribute to the development of hypotension because of the impaired filling of the left ventricle. And typically when you perform a bedside echo, you will see a D-shaped morphology of the right ventricle. This slide comes from a very old publication in Circulation, that demonstrates in experimental situation that you get, this, in case of a right ventricle infarction, you get equilibration between the left and the right ventricle with equilibration of all the filling pressures, like in constrictive pericarditis. And after removal of the pericardium, you see this, that this equilibration disappears. And this is an illustration how in the case of right ventricle infarction, when the right ventricle starts to dilate, eventually exaggerated by this infusing too high volumes of fluid into the circulation, this may induce this constrictive phenomenon on the left, on the filling of the left ventricle. When you perform this bedside echo, it is also important to look at the activity of the interventricular septum. When in a right ventricle, in a pure right ventricle infarction, thus the interventricular septum does not participate in the infarction, then you have still a normal contractility of this the interventricular septum, and during systole, dus the ventricle will contract, and you will see this that the interventricular septum moves a little bit towards the right ventricle. But in the case that you have a severe right ventricle infarction with also septal ischemia due to the presence of a proximal LAD stenosis, or if this, the infarction is extending into the interventricular septum, then you have this a stiff interventricular septum that is not hemodynamically active, is not contracting, but during systole of this, the left ventricle, because of the pressure increase in the left ventricle, which is much higher than the pressure in the right ventricle, you will get a dramatic piston-like movement of the interventricular septum towards the right ventricle, and this will further impair the function of the right ventricle, and this will further contribute to the development of cardiogenic shock in the presence of a right ventricular infarction. Frequently, this we also many of the patients with cardiogenic shock, because they are in multi-organ failure, they need to be ventilated. When you use positive ventilation pressures, this may also have a negative effect on dus the cardiac hemodynamics in patients with cardiogenic shock. You have effects on the heart itself because of the increased pressure in the thorax, but there is also an effect on the microcirculation that results in a compression of the microcirculation that will lead to an increased pulmonary vascular resistance, and this may have a detrimental effect of this, the hemodynamic situation. Certainly in patients with right ventricular infarction. So in summary, cardiogenic shock complicating MI is a complex, self-perpetuating pathological process that frequently causes death. Also in modern times, up to 50% of the patients with cardiogenic shock will die from it. The development of shock depends upon the amount of the ischemic myocardium, usually more than 40%, stroke volume and peripheral vascular resistance. Cytokine release triggers a systematic inflammatory response syndrome, causing a fall of systemic vascular resistance and an inadequate coronary perfusion pressure, resulting in a further downward spiral of progressive shock. So shock begets shock, and supportive medical therapies and assisted ventilation also may have adverse side effects leading to worsening of cardiogenic shock and its clinical outcome. Thank you for your attention.
Thank you so much for the nice overview of the pathophysiology. So do we have any questions, comments from the audience? If you have a question or comment, please approach the microphone or send a question via application? If not, Dr. Wirtz, you nicely overviewed the pathophysiology, and you also described the definition which we use of the cardiogenic shock. Of course, we have to draw a line somewhere, but other than that, I would like to hear your opinion on the fact that cardiogenic shock, if we take away the definition, is like a continuous phenomenon. So you have severe, less severe, and I would say very severe, and different stages may call for different therapeutic approaches according to the severity. What's your opinion on that?
There are indeed different phases of cardiogenic shock, but I did not mention you have patients who present immediately with cardiogenic shock, and you also have patients who develop cardiogenic shock later on. And of course, there are different grades of cardiogenic shock. When you have signs of multi-organ failure already present is of course a more severe situation, and indeed we need sub definitions of cardiogenic shock in order to better classify the patients, but what we mostly need is more information. If you look at the literature, most of this information we have on the treatment of cardiogenic shock dates from the shock trial, which has been published in more than 20 years ago. So we need more research on cardiogenic shock.
We have one interesting question from the audience. What are the new directions in cardiogenic shock pathophysiology research, in your opinion? So new directions in the research of pathophysiology.
Yeah, one of the possible ideas that we have is that maybe we are very efficient in organizing primary PCI in patients with cardiogenic shock, and the decision to install mechanical support is frequently taken very late in the process, and maybe we have to consider to use more early mechanical support in those patients, and we will start recently with a multi-center study that will look at an early start of this mechanical support with installing ECMO immediately in the cath lab, so that we have an excellent situation of support already very early during the treatment. There is also another group who is investigating the use of Impella, also very early in the phase of treatment. This can easily be installed during the intervention in the cath lab.
Thank you very much.